All right. So we're going to talk about arthritis of the wrist. Can everyone see the screen, eh?
Yeah, we can see it.
Okay, cool. So we'll go through this tonight. So SLAC, SNAC. So SLAC is scapholunate advanced collapse. SNAC is scaphoid non-union advanced collapse. Then post-traumatic OA, inflammatory arthritis, STT arthritis, and primary OA. Okay, so as I said, that's what they stand for: scaphoid non-union advanced collapse and scapholunate advanced collapse. So the classification was done by Watson and Ballet in 1984. And this is what it involves. Sorry, I'm just fiddling with my screen here just to get it out the way. Okay, so with SNAC wrist, SNAC 1 and SLAC 1 are pretty much the same, and SLAC 4 and SNAC 4 are pretty much the same. The difference comes in stage 2 and 3. So with SNAC stage 1, the arthritis develops between the distal scaphoid and the radial styloid. And in SLAC wrist, again, it's the distal scaphoid and the radial styloid. With stage 2, it becomes a bit different. In SNAC wrist, it develops between the distal scaphoid and the radial edge of the capitate head, whereas in SLAC wrist, the arthritis spreads to the whole of the scaphoid fossa. In stage 3, becomes a bit more similar. This is where the capitate head, the whole of the capitate head gets involved in SNAC wrist, and then in SLAC, the capitate head tends to migrate proximally and becomes arthritic. Stage 4 is the same in both, where it's basically pan-carpal arthritis. The whole of the midcarpal joint and the whole of the radial carpal joint are involved. Okay, so excuse the old pictures here, but so stage 1, just illustrating it, this is the scaphoid non-union here. The arthritis is developed between the distal scaphoid and the radial styloid. In stage 2, the capitate head and the distal scaphoid are involved, and then in stage 3, the whole of the capitate head gets involved. One important thing to know is in scaphoid non-unions, all of them will progress eventually to SNAC wrist. So that can be 5 years, 10 years, 20, even 30, 40 years. Sometimes patients only present. You may see someone in their 60s who presents with advanced SNAC wrist, and they'll tell you that they injured their wrist when they were 21 playing rugby, and it never gave them much of a problem. So it can really take a long time to develop. In SLAC wrist, here the styloids involved with the distal scaphoid. The proximal scaphoid fossa is still preserved. In stage 2, the whole of the scaphoid fossa gets involved, and then here in stage 3, you can see the capitate head is migrating proximally and the midcarpal joint is involved. And this is different to the SNAC wrist, whereas not all scapholunate instabilities progress to SLAC. So it is a bit debatable sometimes if it's with actually repairing a scapholunate insufficiency, but that's a talk for another time. So the treatment for SLAC and SNAC, initially, as in most things, it's conservative, brace to begin with, analgesia, activity modification, and when that fails, then offer the patient operative management. So in stage 1 for both SNAC and SLAC wrist, the treatment is a radial styloidectomy, and you reconstruct the problem. So in the SNAC wrist, you take away the styloid and then you fix the scaphoid non-union. Once the scaphoid non-union is fixed and united, then it shouldn't progress any further. The same with the SLAC wrist, you take away the styloid, which is the arthritic joint, and then you do a scapholunate reconstruction. And if that's successful, again, it shouldn't progress. Stage 4 is pretty straightforward. Both the midcarpal and the radiocarpal joints are completely involved. So there's no joint sparing or motion preserving procedure. So the treatments there are either total wrist fusion or total wrist replacement. So it's really stage 2 and 3 where we can offer these motion preserving procedures. And they essentially are either a midcarpal fusion or a proximal row carpectomy, which we'll go through now. So with a midcarpal fusion, what you're doing is fusing the arthritic midcarpal joint, and you want to preserve motion through the radiocarpal joint. So this is suitable in both stage 2 and 3 of SNAC and SLAC wrist. And occasionally you do get patients who present with primary midcarpal arthritis, and that can also be treated with a midcarpal fusion. So the prerequisites for this procedure is that you have to have a normal ulnar, a normal proximal lunate and a normal lunate fossa in the distal radius. As we'll go through now, you remove the scaphoid, which is arthritic. So all the motion is going to happen between the lunates and the radius. So here's a few examples. This is SLAC 3. So you can see the whole of the scaphoid fossa is involved, and the capitate head is just starting to migrate proximally. You can see this capitolunate arthritis just over there. This is a SNAC 2, where the distal scaphoid is involved and the radial side of the capitate head is involved. And then this is primary midcarpal arthritis. You can see destruction in the midcarpal joint, no joint space there, lots of cysts, but the whole of the radiocarpal joint here is still pristine. So you can do a 4-bone fusion, a 3-bone fusion, or a 2-bone fusion. So the 4-corner fusion is the one which everyone knows about and has been done for years. So what that involves is you excise the scaphoid and you fuse the midcarpal joint, which is basically all the other bones in the wrist. And then the motion is retained through the radiolunate joint. There's various ways you can do that. There's a plate, there's headless screws, but this is kind of falling out of favor. But the better option is a 3-corner or 2-corner fusion. So the difference between a 4 and a 3-corner is that you excise the triquetrum. The advantage of this is that there's one less bone to fuse, and it's been shown in cadaver studies that improves the range of motion marginally, but slightly better, radio-ulnar deviation and wrist flexion. The other good thing is that the triquetrum is a good source of bone graft, because often in these cases, especially in a SNAC wrist, the scaphoid is sclerotic and avascular, and it's not a good source of bone graft. So if you do need to pack bone in the midcarpal joint, the triquetrum is a good source for that. And then it can reduce ulnar-sided wrist pain. Sometimes you can get ulnar-carpal impingement between the triquetrum and the ulnar head. If the triquetrum's gone, then this can't happen. Basically, the 2-bone fusion is fusing just the capitate and the lunate, whereas the 3-bone fusion is including the hamate in it. There's no real difference in outcomes between these two, but the 2-bone fusion is obviously a little bit easier because you just have to denude the cartilage between the lunate and the capitate and compress those two, whereas with the 3-bone fusion, you include the hamate and you have to decorticate that joint and get good compression. One thing to consider is you get 2 types of lunates. You get a type 1 and a type 2 lunate. The type 1 lunate has got a single articular facet with a capitate, and the type 2 lunate has an extra little facet which articulates with the hamate. So in the type 2 lunate, you'll probably err more towards including the hamate in the fusion, whereas the type 1 lunate, which is the more common one, you can probably just get away with a 2-bone fusion. I'll show you a picture of the type 2 and 3 lunate shortly. So fixation methods, there's the spider plate, which has been used for a long time. This is really just for the 4-corner fusion. There's various shapes and designs, and it's supposed to work that you put screws in all the 4 carpal bones and then they unite. Problem is it's often quite bulky. It's very difficult to get compression across the various bones, and non-union rate is a bit high, and the hardware can also cause issues. The technique we prefer here is headless bone screws, which are inserted through the lunate into the capitate and maybe the hamate. Advantage of this is there's no hardware at all. And then another technique is using staples. But again, here sometimes you can have dorsal hardware problems and get impingement against the distal radius with wrist extension. So our preferred technique is using headless screws. So this is an X-ray of an old spider plate. You can see here there's a non-union here. There's lucency around the screws, and the wrist looks in neutral position here, and that's already impinging against the distal radius. The newer plates are much more low profile. They're radiolucent. Some of them claim to be able to allow you to do compression across the bones. This plate on the top right here has got the locked screws are the blue ones, the non-locked screws which allow compression are the gold ones, but they still often have their hardware issues. And again, like I said before, there's no point in including the triquetrum in the fusion. So as far as I'm concerned, and a lot of people are concerned, a four corner fusion is really, for the history books, you should be doing a 2 or a 3 corner fusion and never using a spider plate. Okay, so the proximal row carpectomy is another option. It's another motion preserving procedure. So what you're doing here is you're relying on an intact capitate head and an intact lunate fossa on the distal radius. So all the motion then is going to happen through that joint. You excise the whole proximal row, the scaphoid, the lunate, and the triquetrum. The carpus then migrates proximally, and the capitate head articulates with the lunate fossa. As I said before, you have to have a normal capitate head and lunate fossa. If there's any arthritis of either two, which happens in SLAC and SNAC 3, where the capitate head is involved, then this procedure isn't appropriate. The patient will have pain and their arthritis will progress. Also, you need to have a radioscapholunate ligament intact, which is the strongest of the volar ligaments. If that's not intact, the wrist is going to be unstable. But in most of these cases, that is intact. It's only really in high trauma cases where you might be considering doing this that you'd have to look out for that. So you can only do it in SNAC and SLAC stage 2. Stage 3, the capitate head is involved. It's also a good option in certain cases of Kienbock's disease. Here's a common feature you get in Kienbock's is a coronal fracture of the lunate. And if you get these relatively early, the capitate head and the lunate fossa are still uninvolved. And then with the proximal row carpectomy, this would be a good option. In more advanced Kienbock cases, these joints are involved, and then you can't do the PRC for that. So which is better? So we said for SNAC and SLAC 2, the PRC and the midcarpal fusion are both good options, both motion preserving. So in this X-ray here, this is a SLAC stage 2. You can see the styloids involved and the whole of the scaphoid fossas involved. The capitate head still looks pretty good on X-ray. There's still a good joint space there, and it doesn't look arthritic. So I'd call this a SLAC stage 2. So if you take away the proximal row, that capitate head will articulate in the lunate fossa and do well. If you want to do a midcarpal fusion, you take out the scaphoid, the triquetrum, and you can fuse those 2 or 3 bones together, and the patient should do well. So that's that option there with a midcarpal fusion. Or if you do the PRC, that's what it should look like. So this is a meta-analysis or systematic review comparing the two. So both have pretty good pain relief, 84–85%. Patient satisfaction is slightly higher in the 4-corner fusion, range of motion a bit better in the proximal row carpectomy, and the grip strength is a bit better in the 4-corner fusion. If you look at the development of OA, the PRC has a higher rate, which is 3.7 as opposed to 1.4. That's because the capitate head isn't as good as the lunate and the lunate fossa. So over time, a percentage of them will degenerate. But the complications overall are higher in the 4-corner fusion, and that's really because of the hardware issues. So non-union rates of 5.5%, dorsal impingement and loosening of screws. But these results are probably mostly from the 4-corner fusion with the plates. If you had to exclude them, I'm sure these hardware complications would be less. And if you look at total wrist fusion, slightly higher in the PRC due to the higher rate of development of OA over time. So sort of a good algorithm to decide between the two. A PRC you're going to generally reserve for a lower demand patient. Somebody who smokes, higher risk of non-union, would probably prefer to do this. If the patient's got quite a stiff wrist already, if you do a midcarpal fusion, that wrist is probably going to get even stiffer, and then they're going to lose the benefit of the motion preserving procedure. So in that case, it would be better off to do a PRC. It's obviously cheaper because there's no hardware issues. So if cost an issue, you'd prefer the PRC. And it's a slightly easier operation as well. You just have to remove the bones, careful not to damage the capitate head or the lunate fossa when removing them. But apart from that, once they're out, that's all that needs to be done. The midcarpal fusion you'd reserve for probably the younger patient who's higher demand. Definitely in a manual laborer, you'd prefer to do this. They've got better grip strength, less rate of degeneration to arthritis, and the higher demand patient you do this in. So as I said before, you do get a type 1 and a type 2 lunate. On the left is a type 1 lunate here. You can see it's just articulating with a capitate head. On the right, this lunate has got two articular facets, one with the capitate and one with the hamate. So in certain cases with a type 2 lunate, this capitate head can actually be quite pointed. In the type 1 lunate, the capitate head is quite round. So this is another thing you may want to consider when deciding between the two. So if you look at this case on the right, that capitate head being quite pointy, that's probably not going to do very well in that lunate fossa. It's not very congruent, and in this case, I'd probably prefer to do a midcarpal fusion. Okay, so we'll move on to post-traumatic arthritis now. This is really mostly from malunited distal radius fractures with large intra-articular steps, large intra-articular gaps. However, saying that, it's actually very rare to see these cases of post-traumatic OA. The distal radius is a lot more forgiving than, say, an ankle or a knee. It's not a weight-bearing joint, so we don't see the same rate of progression to post-traumatic OA that you'd see in the lower limb fractures. It's often associated with scapholunate and TFCC tears as well, so you bear that in mind, which may need to be addressed at the same time. And really carpal fractures can cause this. Carpal fractures, apart from the scaphoid, are very unusual, but occasionally we do see lunate fractures, which can then cause post-traumatic arthritis. So again, initial treatment would be conservative. When that fails, then operative. And your options here, again, probably your first choice would be a motion-preserving procedure. And in this case, the midcarpal joint is generally not involved. So it's really the radiocarpal joint, being the radioscaphoid and the radiolunate joints, that would be arthritic. So that can be solved with a radioscapholunate fusion. If that's not an option, then we look at either total wrist fusion or total wrist arthroplasty. The PRC and the midcarpal fusion aren't options here because the lunate fossa is arthritic, so neither of them will work. So to decide if you can do a partial fusion, you need to assess which joints are involved. Usually X-ray is sufficient. If you've got the time and the money, MRI is an option as well. And then some people will do an arthroscopy to check the joint surfaces. My preferred technique would be just to go into theatre with both options available, planning to do a radioscapholunate fusion. And if you get there and it's not an option, then you can convert to a fusion or arthroplasty. Obviously, you'd have to consent the patient to both beforehand and just tell him that you'll only know when you get in there. So the radioscapholunate fusion, the distal radius is fused to the scaphoid and the lunate, and the motion is retained through the midcarpal joint. So you see here, I've removed the triquetrum and the distal scaphoid. And the reason we do that is because this used to be done quite a lot in the past, but old papers showed very poor results. This 1997 paper had 30% non-union. Only half the patients were satisfied, and there was a high conversion rate to total wrist fusion. And the reason that happens is that the scaphoid bridges the midcarpal joint. So it's involved in both the proximal and the distal row. So if you fuse the scaphoid to the distal radius and you're trying to keep motion through the midcarpal joint, whenever the patient moves their wrist, that midcarpal joint is going to be toggling on the scaphoid, and you'll get scaphoid motion. And that's the reason why there was such a high non-union rate, and a lot of them didn't move well and they progressed to arthritis. So with these results, it fell out of favor. And then only when people realized what the problem was, then they started to excise the distal scaphoid. And by doing that, then you unlock the midcarpal joint, and midcarpal joint is free to move. It's not hindered by the scaphoid. So the results are much better when doing that. The results now, if you look at some recent papers, some of them even having no non-union rates, 0 non-union rates after 10 to 15-year follow-up. And again, here it's worth excising the triquetrum. Cadaver studies again show better range of motion, Again, it's a good source of bone graft if you do need to put bone graft in there, and it unloads the ulnar side of the wrist, so less chance of ulnar carpal impaction against the radials, against the ulnar head. So the amount of scaphoid you need to excise is just at the styloid. You just go obliquely across to the capitate head. You can take a large portion, as I did here, as long as there's enough scaphoid to contain the capitate head, which you can assess at the time of surgery. There's various fixation methods. My preferred technique is staples. It's quite easy to visualize the hardware going in, and the staples have got memory staples, so the legs converge, and it's quite a good technique to compress. It's good to use 2 staples in each bone because one is not rotationally very stable and can cause non-union. So staples are my preferred technique. I have used dorsal plates before, but usually I use those in cases where the anatomy is quite distorted. So in bad distal radius fractures where the distal radius is very odd. Sometimes you have a large overhanging lip and the staples won't get down onto the scaphoid and the lunate. So that would be the option in those cases. Another option would be headless screws. This picture is probably, I would prefer to do 2 screws in either joint. And then another option is K-wires. K-wires don't give you compression though, may cause more hardware issues, so I wouldn't recommend using that. Okay, once you get to pan-carpal arthritis, the whole of the radioscaphoid, the whole of the radiocarpal and the midcarpal joint are involved. So there's no motion preserving procedure that's an option there. So here you either look at total wrist fusion or total wrist replacement. The wrist fusion gives you a permanent pain-free solution. It does sacrifice all the motion in the wrist though, so it does decrease the function, but it's definitely the preferred procedure worldwide and is much more commonly preferred than a total wrist replacement. Total wrist replacement is much newer on the market, but it does give a good pain-free option and maintains range of motion and gives patients better function. They're definitely happier with a replacement rather than a fusion, but like any joint replacement, it doesn't last forever and you have to select your patients carefully. So in a manual laborer who's 20 years old, you definitely wouldn't offer them a total wrist replacement. They'd be better off with a fusion, but if it's a 65-year-old lower demand patient, they're a much better candidate for a replacement rather than a fusion. So just briefly with a total fusion, it's done through a dorsal approach. Your options for fixation are either intramedullary or extramedullary. Intramedullary being a big Steinmann pin. We prefer those in the inflammatory arthritis, rheumatoid patients where the bone is soft and they have very thin skin. Extramedullary prefer in a non-rheumatoid patient, which is a dorsal plate and screws. It's important to consider the position of the wrist when you fuse it. The best position is slight wrist extension that allows better grip and better function. But if you're going to be doing bilateral wrist fusions, it's best to fuse one in slight extension and one in slight flexion. The main reason for slight flexion is being if the patient needs to go to the toilet, they have to wipe themselves. It's very difficult to do that if your wrist is fused in slight extension. So that's the main reason to fuse one in slight flexion. So this is the plate. Basically, it spans the whole carpus, fixes onto the 3rd metacarpal. Some of the newer plates now allow options to the 2nd metacarpal. You have to decorticate the whole of the carpus, midcarpal, and the radiocarpal joint. Occasionally, some people prefer to do a proximal row carpectomy first and then fuse the wrist. So you've just got the capitate and to fuse to the distal radius. However, you do shorten the carpus there and it does result in slightly lower grip strength. So it's better to keep the carpus out to length when you fuse it. Some of the newer plates now exclude the CMC joints. You can see here the screws, they're going volar to the joint here. And some patients prefer this because there is a slight give in that CMC joint. So some people compare it to the feel of a wooden hand, where a wooden hand would touch a desk or a wall. It's very rigid, whereas if you touch your hand on a desk or a wall or pick up something, there's a very slight give, and patients actually prefer it. So I prefer to do this. as opposed to a CMC spanning fusion. If we look at total wrist replacements, they've been around quite a long time. There's been many designs over the years. None have been great. These are quite a few from the past. All of them are ellipsoid articulations trying to mimic the carpus. This is a biax, the Maestro. Both of these two on the left have been taken off the market due to poor results. These two, this is the Remotion, this is the Freedom. They're still around. The problem with all of these is the fixation in the distal carpus. It's not great. There's a lot of movement there. They tend to get osteolysis. So we're still looking for the best design of prosthesis. You know, hips have been around for a lot longer. The designs are a lot better now, but compared to hips and knees, wrist replacements are still in their infancy in regard to getting the best articulation. What we prefer in our unit is to use the Motec, which is slightly different. So this is a ball and socket articulation as opposed to the ellipsoid articulation. And this has got a very good distal fixation. So it's a cementless prosthesis, which you insert through the Capitate head. The whole of the proximal row is removed. And the fixation, this is grit blasted with titanium. And the fixation really is mostly in the metacarpal. And it tends to, it gives pretty good stable fixation. The ones that do fail do still fail in the distal side where they loosen, but it's a very stable articulation, very low rate of dislocation, and the results are coming out now. 10 years, very good. So this is our choice when it comes to a wrist replacement. Okay, inflammatory arthritis, it's a big topic, so I'm not going to talk too much about it. Rheumatoid is obviously the one that we see the most, but we do see psoriasis, SLE, ankylosing spondylitis. So the hand and wrist are very involved in rheumatoid, although these days we're seeing much less of it due to the disease modifying agents. Methotrexate really did revolutionize treatment of rheumatoid, and it's quite rare now that we see patients with these destroyed joints, such as you see on the top right there. But occasionally we do get the older patients who have had it since a young age, before methotrexate was around, and they do come to us still with these sort of deformities. So the features that you get in the carpus subluxes volarly, you get ulnar translocation, and then the wrist deviates radially, and the carpus supinates. So that's the pattern of collapse in the carpus. You get a caput ulnar, which is where the ulnar head subluxes dorsally. It's often arthritic and has sharp spikes of bone, and then this causes tenosynovitis and tendon ruptures. Tendon ruptures in rheumatoids are nearly always due to a sharp spike of bone on the ulnar head. It's very, very rare that you'll actually see a tendon rupture purely from tenosynovitis on its own. Then you get the finger deformities, mostly MCP joint subluxation and ulnar deviation, and then the other finger deformities such as swan-necks and boutonniere, as we see as well. So the issues when treating these patients is function is often much better and pain is much less than the x-ray would suggest. So you can see a patient with a completely destroyed wrist on x-ray and they don't have much pain and they've got pretty good function. So it's really important that you treat the patient and you don't treat the x-ray. Two things to really be aware of is these patients are often quite osteopenic. They have soft bones, so that's something to consider with fixation of any hardware that you're going to put in. Their skin is thin. They're often quite thin, so when it comes to doing something like a wrist fusion, a dorsal plate can be quite bulky and cause problems, so you may want to consider that. So sometimes we see them in the intermediate stage where the carpus is just starting to fall off and go into the deformity that I mentioned just now. If you catch these patients in the intermediate stage where this is starting to happen, you can stabilize the carpus with a chamois fusion. That's just fusing the lunate to the radius, and then that prevents the carpus falling off. But I must say it's very rare that we actually see them in this stage. Late stage, which is normally when we see them, and these stages when it's arthritic, all the joints are involved, there's no motion preserving procedure there, so it's either total wrist fusion or a total wrist arthroplasty. Having said that, most patients that we operate on in rheumatoids, it's usually due to a DRUJ problem. So the ulnar head has caused tendon ruptures. They have pain with pro and supination, and that's the main feature which will make you excise the ulnar head. When you're going to operate on those patients, to assess the radiocarpal joint, you need to flex and extend the wrist. Most of them don't actually have pain with wrist flexion extension, and then you don't need to do anything to the wrist. You can excise the ulnar head and address the tendon issues, leave the carpus alone. The minority have radiocarpal pain, which is pain with wrist flexion extension. Those are the patients that you'd need to either do the fusion or the arthroplasty for. So usually in the advanced rheumatoids, they've got soft bone, poor skin, as I said. So we prefer to do an intramedullary fusion. These are Steinman pins. The carpus is really destroyed already. You open up dorsally, use a nibbler, munch up the carpus, take away any cartilage, and then you put the Steinman pin in from proximal to distal, come out the metacarpal head, reduce it, and then put the Steinman pin down the radius. There's two techniques to do it. This is the Manifeld technique and the nail buff technique. Really, not one is better than the other. We judge it by where you look at the pre-op X-ray. You look where if you draw a line down the distal radius where it's exiting. In this patient, it would be in the first web space, so that's where we come out. It doesn't cause any problems there. If the carpus is lining up with the metacarpal, then we go intramedullary into the third metacarpal. But both are good options. If you do have a patient like this who's rheumatoid but doesn't have too much osteopenia, decent skin, you can do a total wrist replacement. Again, here you always need to address the ulnar head, either with Darras. We do a matched resection to match the resection of the ulnar head to the distal radius. But a lot of patients, you wouldn't want to do that, and you just opt to fuse it rather if their bone is poor. You nearly always have to address the tendons as well. Tenosynovitis is very common in the rheumatoids. It's quite often confused with a ganglion, but you can see on these pictures, the ganglion is usually just a solitary, round, firm lump, which is mostly over the dorsal scapholunate interval. The tenosynovitis is often dumbbell-shaped, where you get a swelling. You can see on this picture on the right here, swelling distal to the retinaculum, and then swelling proximal to the retinaculum. That's where the synovitis bulges out from under the retinaculum both sides. It usually moves with the tendons as well, so with the flexion and extension of the fingers, these lumps do move as opposed to the ganglion where it doesn't. So you address this at the same time as you're doing the bony surgery, and that would be a tenosynovectomy. Tendon transfers, if you've ruptured any extensors, you can see on the right here, it looks like the ring and the little finger are ruptured here, to transfer ERP probably to the little and buddy, the middle and ring. There's various options you can do. And then you do a retinacular rerouting procedure, which is where you open up the retinaculum, sort out the tendons, and then you suture the retinaculum back together deep to the tendon. So basically it's protecting the tendons against the joint, so it reduces the chance of rupture from any bony spicules from the joint. The DRUJ needs to be addressed. Usually the Darras is the one that everyone does. Match resection is described by Watson. This is our preferred method. We match the cut in the distal ulna to the curve of the distal radius. One of the big problems with the Darras is if you cut it shorter, you get ulnar stump instability where the ulna impinges against the radius. You still get that with a matched resection, but because the surfaces are matched, it's less likely to be symptomatic. A Darras is where you usually do a transverse cut slightly higher, slightly more proximal, and with loading the wrist, this ulna impinges against the radius, and you often see a divot in the radius, and these patients are quite painful, and that's very difficult to sort out once that's done. Suave Kapanji is another option, but results aren't great with this. It's being done less and less. You still get the problems of the instability of the ulnar stump. The stump would load against the radius, so it's not recommended. Total replacement is an option, but this is really just a salvage, and it's not even available in this country. It costs about 120,000 Rand, so we don't ever do that. Okay, so we'll just talk briefly about STT arthritis. This is quite common. It's arthritis between the scaphoid, the trapezium, and the trapezoid. You can see that really sclerotic area there. These patients present with pain in the radial side of the wrist, often in the volar, just distal to the scaphoid tubercle on the volar side. It's common, 2 to 16% of the population, similar to base of thumb arthritis, more common in postmenopausal women. The majority are not symptomatic though, very similar to base of thumb arthritis. So again, treat the patient, not the x-ray. In this case, it's mainly the STT joint involved. The CMC joint may be slightly involved, but okay, but you need to assess that as to your treatment. You must determine if the thumb CMC joint is involved as well, or if just the STT joint is involved. So as I said, they get radial-sided pain, and the FCR tendon inserts on the base of the second metacarpal. So it goes right over the distal scaphoid. So if you've ever seen volar approach the scaphoid, you have to take the FCR out the way. So when you get arthritis of this joint, you can get little osteophytes there, and that can irritate the FCR tendon. And the patients often present with just FCR tendonitis as a first symptom of the STT arthritis. Occasionally the tendon ruptures. Usually once it ruptures, similar to like a long head of biceps problem in the shoulder, when the FCR ruptures, then that normally sorts out the pain, and it's not an appreciable loss of wrist flexion. So you would rather just leave it alone when that happens. So treatment, conservative, you can try and inject into the joint. It's very difficult though. It's a hard joint to inject at the best of times, in an arthritic joint which is narrowed. It's very hard, but even just injecting cortisone around the joint does give patients relief. So that would really be, multiple injections would be the first line of treatment. You can try splinting and activity modification. If that fails, then you're looking at surgery. So if the CMC joint is involved, you have to do a Burton Pellegrini or a trapeziectomy and suspension plasty, either with a tendon interposition or a tightrope. Any of those techniques, we do the Burton Pellegrini, which is the FCR interposition. But by excising the trapezium, you decompress both the STT joint and the CMC joint, so you solve both those problems. Problem with the Burton Pellegrini, it does weaken the grip and the pinch. So in cases where the CMC joint is not involved, then there are better options. Various techniques here. This technique is excising the distal scaphoid, and then you're doing the tendon interposition using FCR. There is an option, the pyrocarbon spacer. They both do well. And then the STT fusion is probably reserved more for the younger, higher demand patients, but it's a difficult joint to get to fuse. As I mentioned before, the scaphoid bridges the midcarpal joint. So by fusing that, you're blocking motion in the midcarpal joint. And as a result, it's a high non-union rate. But in a young patient, that's what the treatment would be. Okay, so that's all. Any questions?